Hello, this is Dr. Bhomik, and welcome to my pediatric endocrine lecture series in my YouTube channel. And the two cases that I am going to present to you with myself as well as Dr. Anne-Marie Coffers, both of them are equally involved in this management of this case. And this case was also presented in Pediatric Endocrine Society, Southern Pediatric Endocrine Society in Atlanta, and was also published at Endocrine Practice, which is the official journal of American College of Endocrinology. In my comment section later on, I will put the link so if anybody is interested to see it in details, and that will be available there as well. So without further ado, is that again I'm the ex-professor of pediatrics and chief of the division of endocrinology, and Dr. Anne-Marie Coffers, when we published this paper and presented, was associated professor of pediatrics, but at the present time she is a full professor at University of South Alabama and the College of Medicine. And this is a little pictures of our Children and Women Hospital, where I spent 21 years of my academic career there. And this is a very nice facility, so I just wanted to like a little bit of show and tell. So my goal and objective here today is present these two cases of 18q deletion syndrome and discuss briefly the incident and major features of this 18q deletion syndrome, and we'll discuss also the endocrine dysfunction observed in our patient, and we'll also do the review of the literature where it is described the endocrine dysfunction with the patient with 18q minus syndrome. We'll also emphasize our patient endocrine problem that was, we felt, unique, that has not been described in the literature, so we will present that one as well. And we will also do the little bit literature review. So what I am going to do is just like case history of one patient and the continue with that discussion and finish that one, then we'll go to the second patient. So there will be less confusion in that way. So this was, the first patient was a 27 weeks old, was born in our hospital with the weight of 1 pound and 10 ounces, and it's an intrauterine growth retardation, and birth length was only 13 inches. The patient was born with a cleft palate, but there was no cleft lip or hair lip, correct cleft lip. Stayed in NICU for 5 months, and in the beginning almost all feeding was G-tube feeding, and then some of the feeding was G-tube, as well as we managed to get 50% of feeding later on by mouth. And this was the firstborn child of mother. Mother's height is 5'4" and dad was 5'8". None of them had any health issue, excepting one cousin of this baby, relation who had Down syndrome. apart from that, family history is quite unremarkable. Physical examination shows a dysmorphic features, and that include a nystagmus, wide spaced eye, flattened nasal bridge, hypotonia, and obviously height and weight in the growth chart. Newborn growth chart was less than third percentile and minus 4.5 standard deviation, and the sex female. MRI in the nursery showed grade 2 to 3 ventricular hemorrhage, and the karyotype was done, which shows 46XX with the deletion of 18. So 18q deletion in distal segment. And this was also verified at 3 years of age with a repeat chromosomal study. At the age of 3 years and 9 months, patient presented to the endocrine clinic with the history of excessive sweating, crying, irritability, jitteriness, insomnia, and polyuria. Was going to the peeing a lot. Physical examination, since this is the thin baby, very clearly a goiter is visible and easily palpable. There was no bruit, however, appreciated over the thyroid gland. Persistent tachycardia between 120 to 130 per minute. And the patient also shows the slow weight gain as well as slow growth. Thyroid function test, which will be coming to the next slide, was clearly consistent with hyperthyroidism. So on this side is all the parameters we got in the beginning, 4 months later, 8 months on therapy. So free T4 at the time of diagnosis was 2.91, clearly very high, and I have put the reference ranges in the bracket down below. TSH was very suppressed, 007. Thyroid stimulating immunoglobulin, which is the marker for Graves' disease, was 384%, significantly elevated. Thyroid peroxidase antibody is a marker for Hashimoto's thyroiditis, which was also present a lower titer, but it was positive. And that at this point, this child was started on methimazole, 2.5 milligram 3 times a day. However, 4 months later, very quickly after therapy with methimazole, thyroid function came down in a hypothyroid range, which shows a free T4 of 0.2 ng, however, significant rise of TSH, 163, and at this point we discontinue the tapazole or methimazole. However, 8 months after the discontinuation of anti-thyroid medication, she again presented with hypothyroidism. Her free T4 was 2.2, suppressed TSH, and TSH this time was almost double of the initial determination. Thyroid peroxidase antibody has gone up to 486 IU per ml, which is significantly positive. With our experience of managing coexistence of Hashimoto thyroiditis and Graves' disease in a patient with Down syndrome, which we actually presented in my YouTube channel as well as published. This time we decided to put this patient on tapazole 200 milligram, 2.5 milligram, 3 times a day with levothyroxine 12.5 microgram daily, and then very quickly brought the tapazole down to 2.5 milligram daily, just to maintain the patient at euthyroid level. So at 5 years of age, this patient is still continue to have normal thyroid function test and still on levothyroxine as well as methimazole. However, significant decline in growth rate was noted, and as calculated and observed rate was 2.5 centimeter per year. We are not going to describe all those details that we have done in terms of workup, electrolyte, CBC, but going only to emphasize the thing which is pertinent to this case. IGF-1 was 55 ng per ml, which is low normal. IGF-BP3 was 3 mg per liter, which is also within reference range, normal. Bone age is 4 at the chronological age of 5 years and 1 month. Growth hormone stimulation test was done with clonidine and arginine. With the clonidine, the peak level was 5.47, noted at 60 minutes. And with arginine, the peak level was noted at 75 minutes with 8.9. And in order to pass the growth hormone stimulation test, the standard is more than 10 or more than 10. We also did a morning cortisol level, which was within normal range, 19.1. So growth hormone deficiency is well known and has been described and published in many papers with the patient with 18q deletion syndrome. So with the family discussion, after the discussion with the family, we did started the patient on growth hormone. The calculated dose, recommended dose was 0.3 milligram per kg per week divided daily dose. But in about 4 weeks after therapy, the patient developed the joint swelling, puffy face, edema of the dorsum of the hand and the feet, and the patient was also very restless and crying. After observing that, we decided to stop the growth hormone. However, parents was very keen to get on the growth hormone as soon as possible, and but this time after a month, we decided to do it a little bit differently. We only gave half of the recommended dose daily, half of the recommended dose. So what was the calculated dose the previous time? We just gave half of it daily, and the patient tolerated that without any problem. So in 6 months, growth rate was observed 3.8 in 5 months and 5 centimeter per year on a low dose. So as I said that there was no side effect noted, and on the other hand we continue with the tapazole and levothyroxine, 2.5 milligram daily methimazole or tapazole, and levothyroxine 12.5 microgram daily. So this patient, now on growth hormone, was on growth hormone, methimazole, and levothyroxine. So what is unique about this patient we will discuss in the discussion section. Now let's come back to patient number 2. This patient was born at 25 weeks of gestation. Birth weight was 1 pound and 10 ounce, and the mother was only 18 years of age, and she was significantly overweight and was mentally challenged, and she was not even aware of her pregnancy, and there has been no prenatal care. The patient came to the emergency room, and the baby was born in the emergency room and quickly transferred to NICU. The mother smoked, drink, and on multiple recreational drugs as per grandmother. Stayed in NICU for longer period of time, over 6 months, and the mother had no involvement in this care of this baby, and the child is being raised by her grandmother. Subsequently, she developed cerebral palsy, seizure disorder, and obviously mentally challenged. The recurrent admission with pneumonia, seizure, and in the hospital was pretty common, but seizure later on was fairly controlled with anti-seizure medication Keppra. Karyotype 46XX with deletion of distal segment of long arm of 18, that done in the newborn period and was also repeated at the age of 4. So at 4.5 years of age, she was found to be hypothyroid with a small goiter, and she also had decrease in growth rate. Her free T4 was 0.7 ng per dl, which is low, and TSH was 46 MIU per ml, which is significantly elevated. Thyroid peroxidase antibody was 52, anti-thyroglobulin antibody was 110, and TSI was negative in her case, and so the patient was given a diagnosis of autoimmune thyroiditis or Hashimoto's thyroiditis and started on levothyroxine 25 microgram a day. Thyroid function was monitored closely, and present time, or the time that our last visit that patient we had, was on levothyroxine 50 microgram daily. Between the age of 5 to 6 years, her growth rate was fallen significantly, and it was about 3.5 centimeter per year. Thyroid function continued to be normal. Growth hormone IGF-1 was 175, and IGF-PP3 is 3.6 milligram. Both of them are completely within reference and normal range. AM cortisol was 18.2. The bone age was delayed by 5 months by Gulick and Pyle method, and grandmother was taking care of the patient, did not consent, or they were not inclined to start on the growth hormone. And we really did not pursue that one, and so he was not on growth hormone. But at the age of 7 years of age, she came to the emergency room with chronic tonic movement and tetany, the spasm of the hand in the emergency room. And at that, in ER, her serum calcium was 6.6 milligram per dl, which is low, and ionized calcium was also low, 0.76, and the reference range in the parenthesis. Serum phosphate was elevated, 6.8. Magnesium was within normal range, 2.1. 25 hydroxyvitamin D was low normal. 125 hydroxyvitamin D was low. Reference range is 20 to 60. And the PTH level was free to 432. The reference between 15 to 65, and the PTH and all these tests was repeated and pretty same result. So here we have a high PTH with the hypocalcemia, tetany, and this baby who was initially was admitted to the hospital and was taken care before discharging at home. We also did a head CT which shows no calcification, intracranial calcification. X-ray of the hands shows no shortening of metacarpal bone. Started with calcitriol or 125 hydroxyvitamin D and elemental calcium. There was no more tetany, and the serum calcium level, thyroid function remained within normal range. However, PTH remained high. So again, the uniqueness of the second case will again present, will describe when you go through the discussion section. Now, 18q deletion syndrome is also known as de Grouchy syndrome, and this is the second most anomaly involving the chromosome number 18, the first being trisomy 18. So estimated rate of 18q is 1 in 40 to 60,000. On the other hand, trisomy 18, which is also known as Edwards syndrome, 1 in 4,000 to 10,000. See the difference. And that's the number one chromosomal anomaly involving chromosome number 18. But as you know, most more chromosomal anomaly that we see in children is Down syndrome. So if you want to look at the statistic, approximately 100 babies born in USA per year with 18q deletion syndrome. There is also 18p short-term deletion, which is rather less common, which is rather uncommon. Interesting to note that 80% of cases are de novo, that means new mutation. 10% of the cases are translocation, and 10% are mosaic with less severe phenotype. And there are some balanced materials That means it's lost, but it is attached somewhere. So our mosaic, so these three, 18, 10 and 10 are kind of breakdown, and that will kind of help us to go along with the discussion. Now then, this is interesting. This is the normal 18 chromosome, and this is 18q deletion syndrome. You see here. Most of the time, it could be distal or proximal deletion, but so both of our patient was 18q distal deletion. Okay, so and this is 18p deletion is right here, and this is a ring form. Here is the normal one, and the other chromosome is in the ring form. Okay. So, is there a particular, like a Down syndrome has a species that you can more or less diagnose very quickly, even without doing any chromosomal test? But this syndrome, since the deletion could be small or large, depending upon the symptom also may vary. So there is no one particular group of sign and symptom that one can identify and tell, okay, this is clinically is trisomy, clinically is 18q deletion. But this syndrome are variable because of the severity of the deletion, and the symptom also more severe with the size of the deletion. As I have mentioned, the second most anomalies of chromosome number 18, which is 1 in 10, 4 to 10,000, or 1 in 4,000 to 10,000. And again, distal deletion of chromosome involving 18 is about 40 to 60,000. And again, the deletion could be in the short term as well. Now here I can show you, this is the distal segment. And again, there is in the distal, there could be proximal deletion of the of chromosome or the distal. So deletion is 12.1 right here to 21.1 up to this is considered as proximal deletion, and the distal deletion is the rest. The key features of 18q deletion syndrome is 97, not almost 100%, they have demyelination of central nervous system. They are hypotonic, and there is many a time a decrease or absence of deep tendon reflex, which was about 75% of the cases, and this is actually was seen in our patient as well. Hearing impairment, mental retardation, and seizure disorder also known to occur, and that I have put this in percentage. Gait abnormality, mid-facial hypoplasia, cleft palate, higher palate is common. Micropharynx and cryptorchidism is noted more than 50% of the male babies. Endocrine abnormality in 18q syndrome has published, and most of the cases it has been limited to growth hormone deficiency and thyroid abnormalities. Thyroid abnormalities that has been reported are mostly autoimmune thyroiditis. So, although the thyroid abnormalities can involve The coexistence of Hashimoto's thyroiditis and Graves' disease, which we saw in our first cases, is seen actually pretty commonly now in Down syndrome babies. So whether the chromosomal abnormality make them more vulnerable to both Graves' disease and Hashimoto's thyroiditis is not very well understood. However, our second patient has pseudo hypoparathyroidism, which has not been reported in the literature. I have reviewed up to the last year and did not find a case of pseudo hypoparathyroidism beside our report that was published in 2021, and as I said that I will put the link in my comment section. Now question here is that is there any reason why they have pseudo hypoparathyroidism, or it just happens to be at random? And since no other case report as far as I know, so this just could be a random, but anytime there is a genetic problem, always has to be kept in the back of mind that whether the other associated problem, just like pseudohypoparathyroidism, is a part of rare occurrence in this group of patient. Now, children with 18q deletion syndrome has some degree of growth failure, as the literature that I have reviewed and suggests that about 70% is growing poorly and their height is less than 5th percentile, and many of them are less than even 3rd percentile. Approximately of 60% will qualify for growth hormone by using the growth hormone stimulation test data. However, like us, there are many cases where IGF-1 and IGF-BP3 has not been low, but they are borderline or low normal. The problem appears to be, most likely, is a hypothalamic level, and the treated patient has done well with growth hormone therapy, and in fact, there is some publication or some belief that growth hormone treatment probably improve the non-verbal IQ and muscle tone. In our patient, first patient, and we felt that there has been some improvement of muscle tone on growth hormone. About 12% of the patient present with hypothyroidism, with a patient with 18q deletion syndrome, and Hashimoto's thyroiditis is the most common type. Elevated TSH, thyroid peroxidase antibody, and anti-thyroglobulin antibody, which is the features of autoimmune thyroiditis, are noted in this patient. However, there are no convincing publication of both thyroid hypothyroidism due to Graves' disease versus autoimmune thyroiditis or Hashimoto's thyroiditis in the same patient. But it probably does exist and not been published, and the physician probably has just treated with the way combination therapy, both anti-thyroid medication and thyroxine replacement. Type 1 diabetes, rheumatoid arthritis, Graves' disease. Per se, only simple Graves' disease is also known to occur, And there is one patient who's I found in the literature who had plain Graves' disease. Annual thyroid screening is probably a good idea because the incidence of thyroid dysfunction is pretty high, more than 10%. So by doing the screening uh, at least once a year, we'll be able to detect that problem, and that will help them not to develop. They have mentally deficient, and hypothyroid will add to it. So that part we can help. So in short, the patient summary: first patient had growth hormone deficiency and Hashimoto's thyroiditis and Graves' disease. Respond well with growth hormone and thyroid function has been normal. And second patient has Hashimoto's thyroiditis, normal thyroid function on thyroxine replacement. This patient was not given any growth hormone since the family did not want, since IGF-1 and IGF-BP3 was normal, so growth hormone stimulation test was not done. Pseudo hypoparathyroidism now has been taken care with the conventional therapy of calcium with phosphorus in combination as well as vitamin D. So in conclusion, endocrine dysfunction is common in 18q minus syndrome. Growth hormone deficiency is most common, followed by hypothyroidism. And this hypothyroidism is usually autoimmune in nature, and it's autoimmune thyroiditis or Hashimoto's thyroiditis. Pseudo-hypoparathyroidism has not been reported in the literature, and its involvement and correlation or connection with 18q syndrome is remain elusive. So monitoring growth velocity every 6 months and thyroid function test yearly is recommended for any patient who not even on growth hormone or thyroid hormone, because those two dysfunction, that two endocrine dysfunction is rather common with this chromosomal abnormality. So my goal here was to present these two cases, and we learn a lot by managing these two cases. So 18q deletion syndrome, as I said, is the second most common of 18 chromosomal anomalies, next to 18 trisomy 18 syndrome. And I think that any endocrinologist or physician who is seeing the patient with 18q deletion syndrome should not only monitor the growth rate regularly, if not every 6 months, but at least once a year. And if the growth failure is documented or growth rate is low normal, then a growth hormone stimulation test might help, and therapy with growth hormone may improve the nonverbal IQ and the muscle tone. And that has been reported in the literature as well. Thyroid function test like Down syndrome patient should be monitored at least once a year when the physical checkup is due. And again, the majority case is going to be autoimmune thyroiditis or Hashimoto thyroiditis. But occasionally Graves' disease can occur. So, although these are not the common cases, but I felt that those who are interested in pediatric endocrinology fellows, endocrine nurse practitioner, and endocrinologists themselves will benefit from this kind of report. I'd like to thank you very much for your attention, and I'll see you in my next presentation.